Fatigue is another way of saying tiredness. And when you get down to it, tiredness happens to be the #1 symptom that any doctor, any healthcare worker is going to see. And so it's pretty amazing that one word, tiredness, kind of encapsulates all the types of problems people have. Let me just tell you a little story. In fact, this just happened about 2 weeks ago. So I have a patient named Joan, and she's 43 years old. And I had seen her a few years back, probably about 7, 8 years ago. And at that time, I was seeing her for palpitations, and she was having some issues, a little bit of stomach problems in those days. And then I saw her a couple years later, and she had gained a little bit of weight, but not much. And she was still kind of nervous and having palpitations. So this time, 2 weeks ago, her main thing, she felt so tired. I mean, she was so tired she couldn't barely even think straight. And I asked her, well, you know, what's going on? And she goes, well, I have a problem with my boss and this type of stuff. And it's been going for about, because I'm asking, well, how long has that been going on, the issue? And it was about 1.5 years, something like that. And I said, well, didn't you have some issues with palpitations before then? She goes, well, yeah. And so then what happened was she basically said, well, you know, I'm just so tired. And you notice when they say that, it's a nebulous word, because you don't know, do they mean fatigue, like physical fatigue? Do they mean tiredness? Do they mean depression? What are they talking about? And that's the type of thing we're going to get into. So finishing up here with her story, so we were about ready to leave, you know, because I had to order a few things and all that. And I turned around and I said, you know, when was the last time you felt normal? When was the last time? And she sat there and looked, and then this look came down her face, and she said, 7 years ago. I said, 7 years ago? Why? She said, that's when I got divorced. That's when everything started happening, just about that. So there ties in a situation where a person comes in, they're very fatigued, they're very tired, but it's gone. This is an issue that's actually been building for 7 years, because that was when she really started noticing that type of problem. So in that situation there, it's a good example how that word fatigue or tired really involves multiple things. It's very easy to talk about the peripheral side versus the central type of tiredness. We'll go into that. And in the end, what happens is we have to put everything together, okay? So let's start off with our little title here. And let's see. I have no remote thing here, so I'm going to work with this at a time. Now, do you remember that you recognize the guy on the right? Who is that guy? It's a TV show, but he's been in a lot of movies, too. That's right, the guy in the office. Starting off here with, here she is, probably 3 o'clock in the afternoon, or first thing in the morning. But you can see she's been working, and she's basically kind of collapsed. How often does this happen? Happens every day. People are like this every day. And here I think this is. He says, I don't want to work. I just want to bang on this mug all day. So he's right now determined that he's going to get his way. Let's contrast the person here. He's waking up in the morning, and he just doesn't want to get up. Looks like one of my kids, actually. They just don't want to get out of bed. And what about this person here? She's pretty amazing. You know, she's got a lot of, look at that altitude there she's got. So some people have just full of energy, and other people don't. And the question is why? Here, this RPE, this has to do with a scale of energy, a scale of you know, how much effort you're putting out to. And we use this actually scale for cerebral stress tests. Person will say, you know, like, what do you feel like with this activity on a scale of 10? Maybe it's a 9, or some scales go to 20. So it's a way of measuring your activity and measuring your effort. And so this here is the word peripheral. So peripheral has to do with the basic way of evaluating energy source. It's the easiest thing to do because it has more to do with straight science. Our science as far as cardiology, as far as biochemistry and all that stuff is pretty advanced, okay? But science of the mind is not, okay? So what's happened is that this is the information that we had gotten initially. Malleable has to do with the fact that a person's understanding or feelings of fatigue are actually quite malleable. And the reason why, what happens is that you have fatigue is peripheral, related to like our muscles, things like that. It also has to do with organ systems, basically the body itself. But then there's another component to fatigue, and that's central. It has to do with the brain. And the brain itself has a tremendous impact on this. And we've always known that if you've worked real hard, you can get depressed, okay? If you're really exhausted, you can get depressed. But the other way around goes too. If you're depressed, you can also feel very fatigued. So there's clearly a relationship going on, but we really couldn't understand it because we're trying to be scientific and we're trying to say it's this and this and this and this. Well, we do have some information now about it, and it has to do with that there is an interaction at the level of the brain. So think of this way. My right hand and left hand here, okay, so right and left. So if there's a specific type of area of the brain called the insula, that is so just look at this as a receiving portion of the brain. So that receiving portion receives the input from our legs, our breathing, etc. So it's getting data, brings in data, and then from there, there's a connection between the insula and also then two other areas of the brain, which then have to do with the motor cortex. So in the end, what happens is that there is a connection between how we feel connected to the motor concept here, the motor neurons, and then from that point on, it has another connection to another part of the brain. And so the end result is our fatigue has been accepted by the insula, and then the fatigue is transmitted to the motor and then to our brain. Now, why bring it up? Because they did an interesting experiment. They took people who were untrained volunteers to do these exercises. Let's just say, for the sake of discussion, was running the 400 meters or whatever it was, running a mile. So they had a whole group of people that were untrained doing this activity. Then they had people who were athletes doing the same activity. They showed with MRIs and all that some interesting things actually showed up. First is the people who were untrained had like 4 separate areas of the brain that were stimulated, and they were phrased as unpleasant activities. That's how it was. So they had unpleasant activities, and all 4 showed up being stimulated, and like bright lights or whatever you call it, they'd light up. Now the athletes had one section. When they looked at the same section, let's just say it was section 4, never lit up. They were trained athletes. They somehow, the brain had been adjusted to make changes based upon the fact that this is like a recurring theme. And they said, oh, I can do this, that type of mentality. Take this, now that's the raw data, that's the research that was done, and that was a few years back, like 2004, 2010, something like that. What they've also found out that kind of goes along with this is that cognitive behavioral therapy is also effective in helping people out. Here, this is the title here, Institute for Functional Medicine. It's a great, great organization, and it's teaching us how to look at medicine completely different. So I've been doing medicine for actually 35 years, 30 years in town as a cardiologist. I started early, back around 1987, and by myself, and my wife can attest that that was a long period of time, working nonstop with no support. So that's how I started, and I got, and I was interventional, so I did heart surgeries and all that type of thing. So interestingly, you end up in a situation where you're taking care of lots of patients, and you realize you can't help some patients. There are some patients, and it has nothing to do with them. It's the fact that there's a limitation on let's say, the paradigm, okay? And so to go outside the box and to help people out is a little scary, but it's necessary sometimes. And that's why I went into functional medicine. So I practice cardiology. I was just practicing up to 4 o'clock this afternoon. But part of that, I also add this extra layer, sort of like an extra mask on top of it to sort out problems. Like example, what I was just talking about, the young woman, Joan, that was a functional medicine type of approach, okay? Because I'm going into in-depth discussion, in-depth questions, because I'm saying, when was the last time you felt normal? And that question is rarely asked, okay? And the reason why is because it's going to take time. Because the patient might be able to figure it out within a space of a couple minutes, but very often, no. And if it's a guy, definitely not. Because, American males, at least my generation, we didn't talk. Name, rank, and serial number is what we did. And the idea is to say as few words as you can when you're in the exam room and get out. Because the longer you're there, the more likely the doc's going to do something to you. Okay, so let's try. Okay. So look at these learning objectives here. Develop a deeper understanding of what fatigue is and where it comes from. Number 2, to identify key clinical data. 3 is not going to be applied. Today's lecture is actually going to be more about why, the whys about fatigue, okay? And also a little bit of what. The second lecture is going to be on how, and like how is it happening, how is it occurring, what's making it occur. But the discussion is so broad that to just think you're going to get everything done in one sitting is kind of crazy. So here we have, you could see this combination of emotions and also of, there you have at the very bottom, neurodegeneration, which doesn't sound too good, but unfortunately it's true. And we do see that, and now we're seeing it in not just old people, we're seeing neurodegeneration in children. We're seeing it in particularly teenagers and early 20-somethings. That's what we're seeing this now, okay? And they present differently. They seem normal, because there's nothing wrong with them when they're born, but as time goes on, they start having problems with their brain function. They start having a little bit of a shake. It's not real strong, but it's kind of one of these subtle shakes, almost like a hyperthyroid type thing, but the thyroid's fine. And the reason they have that is because of a problem with gluten enteropathy, so they have allergies to hybridized wheat, and that causes a reaction to the brain. And it's actually a real problem that's not really being addressed, So that problem is very similar to 1961, and everybody's saying that Marlboro cigarettes are safe and they're fine for you, okay? And the answer was no, they weren't. They knew that in the 30s, but they didn't talk about it. So here again, these different levels of activity. So we have athletes who can push their bodies. This is similar to what was shown before with someone who was bright-eyed, bushy-tail, and then here she's having a rough time waking up. And here it doesn't matter what age it is. We've got someone who is, she must be at least 80, and she looks great. And she's a little bit less than 80, I'd say. And here's our 3 o'clock blahs. And I have to tell you, there's a lot of people who have this. I had it myself. So it's one of these things where sometimes it's related to a lack of sleep. And I'm going to go into the specifics, but these are the different, basically the different visions and perceptions of what fatigue is about. So again, these are pretty much similar to the list I gave you there that was in the black sheet. And here it says tiredness, somnolence, sleepiness. See, they all fall in the same category. Exhaustion, lethargy, listlessness, weakness, decreased loss of consciousness, brain fog, powerlessness, depressed, amotivational, apathetic. You could see over here on this side, you could see this is more of an emotional tone on the right side. And working definition, I love these definitions. they're almost worthless, but somebody's got to put it together so they can write a paper, I guess. It says here, persistent and subjective sense of physical, emotional, and or cognitive tiredness or exhaustion that significantly interferes with desired functioning. Why couldn't you just say I'm tired? You know, it's going to say the same thing, and this is no more clearer than saying the word tired. And then here, this was I was referring to before as far as the RPEs, which is, you know, we don't need to go into details about that. The peripheral fatigue, I won't gross you out, but the next slide is kind of a grossy one. That's a frog lab. But that's where things started. That's where things started because we're dealing with the mechanical aspects. And here, this will not be discussed today, but I thought it was relevant so that people do realize that we're talking about on one side of the coin is peripheral fatigue, and you can see that they're starting with the heart. And then because of decreased blood flow to the muscle, that fatigues out, and the mitochondria impact because of decreased blood flow. So this is from a few years back, and this was actually updated because there are some doctors in South Africa that have spent a lot of time on this. And I guess they just perseverated on one thing, but they did a lot of good work on this. Here's what I was saying about the central fatigue is a complex emotion. It is, no questions asked, this is the core of our problem. And how many times have I had patients who came in because they had chest pain and palpitations, but the real problem was they were stressed out, they were fatigued, and they really didn't know what to do. And it just showed up. It just showed up as palpitations. That's what it was. It wasn't like they were having a real heart problem per se, but what we saw there was we have a patient who is stressed out under a lot of different types of emotions, and then that leads to the heart going faster and then creating the palpitations, and that's how I end up seeing them. And in the 80s, I saw a lot of patients that way because things were more open. You could see whatever doctor you wanted in those days. And nowadays, we have to have some fancy diagnosis for me to see them. So here we can look under the second aspect. Fatigue is a complex emotion affected by motivation and drive, anger and fear, memory of prior activities, definitely. So these are this has to do with a primary reasons for having fatigue. So that's like the substrate. Now this is an interesting comment. This is a comment by an Olympian. Now this guy is not like our famous swimmer from Baltimore, you know, who's got 20 gold medals or something like that. He only has 9 gold medals. So we'll cut him a slack here. And but here he says, mind is everything, muscles are pieces of rubber. All that I am because of my mind. So it sounds pretty profound, but there's truth to it. There actually is. When you get to the high level, it really has to do with what's upstairs for determination that makes the guys win. And this one here I'll be discussing on our part 2 because it just to show you how many other, if we look at the very top part, emotional state and extent of mental fatigue, sleep deprivation, level of motivation, these are all parameters that impact the emotional state. And this here is, I put this in for a reason, and it's kind of like to put down, in a way, traditional medicine, because I was there, and I could tell you it was the truth. 1988 was when chronic fatigue syndrome occurred. That's when they actually created the phrase. And nobody really understood what it was, and typically for the first 10 years, maybe 15 years, the assumption was the patient was crazy. It was one of these like a basket type of case where people who had this, who were given this diagnosis, were thought to be crazy. As time went on, we realized that's not true at all. Now here we go into a little more details for it. This comes from the CDC, from the government. And this is all the, if you notice what it says medical exclusions, medical exclusions. So for that reason, that means if a person has emphysema or hypothyroidism, they can't have chronic fatigue syndrome, okay? Okay, so just remember that statement there. Now we go to the next level, and this has to do with the psychiatric side. So now we have the psychiatric exclusions. But now look at what it is. Bipolar, schizophrenia, delusional, dementia, organic brain disease, essentially everything that you have. So then what happened was, as time went on, which wasn't too long, much after, many years after this, it boiled down to that fatigue and the symptoms of fatigue are very similar to just what anybody would have if they've been ill for 6 months or more. That's it, because all the symptoms are the symptoms that we get when we're sick. It's that simple, because it's the symptoms so varied that it turns out that you're fooling yourself if you think it's a special diagnosis. Now we'll go into, and here's the treatment. And what I mentioned before was there is a treatment for chronic fatigue syndrome, and what it boils down to is mild, progressively increasing exercise. That's number one, and number two is something that's going to impact the brain function. Now, a lot of people, they would just put them on serotonin antagonists, like your typical antidepressant medications. So those people actually did do better, but CBT is the cognitive behavioral therapy. And the reason why it works, we think, is because if you go back to what I was saying about the receptors, the insula on the right and left side, so this is receiving information from the rest of the body, all right? And then when it has this connection to the motor cortex, there's something going in between which allows it to modulate. So this goes from here, and then if you get the specifics, the anterior cingulate gyrus, we're going to this level. But before it goes from here to the brain, there's some additional processing going on, which alters the way the person thinks. And what they found out was they're able to figure out, some of the cognitive behavioral therapies are able to figure out which circuits there are and retrain the brain. So when you retrain the brain, this is not like overnight. This is not like hypnosis or something. This is like they're doing maybe 2 hours, 3 hours every single day for maybe 4 months for this to occur. But they retrain the brain, and with that, they don't have the fatigue or whatever the symptom they actually had prior. So it's pretty interesting work. But this is one of the earlier things that was done to prove that this is not simply a mechanistic type of thing, where your ATP is low and things like that. So, and here it says here, works because fatigue is an emotion that can be modulated to a degree. In the cognitive behavioral therapy, works because fatigue is soft-wired, in particular brain networks that can be rewired. So you say to yourself, what does that really mean? But it's basically what I was saying. The brain has a way of adjusting. Think about this. If you have a cat and the cat is put upside down, and that's the way they see the world, they adjust. The brains adjust. So the brain's pretty amazing. It's very plastic, as they say, and it can adjust very easily, or at least eventually it would be adjusting. Now, this just goes into a little more detail about the discussion I just gave, which we don't need to go into that. Okay, so this is the more important area here. So what I'm doing now is knowing full well that fatigue, or the word tiredness, actually applies to emotional issues as well as peripheral issues. We'll start with how to do the evaluation, okay? And if you look at the number one is open up the storybook of fatigue. So what we're saying is, if you're talking to a friend, if you're talking to a loved one, or me talking to the patient, you ask them what's bothering you. And normally, they're going to give you a simple answer, and it's not going to be sufficient. So you have to be a little bit more, you have to take some time, and you have to go back and start asking some more thorough questions as far as when did it start and all that. And then later on, you can hit them with the question that I gave, which is kind of like the home run question. You know, when was the last time you felt that way, or felt normal, I should say. Number 2 is find sentinel symptoms of fatiguing illness. So there we're talking about is a list of problems that the patient is exhibiting. And let's see if I got. I'll let that be. I can work through this way. Okay, so this is the pioneer for American medicine. This is Sir William Osler. He basically started American-style medicine in the 1890s. And he's actually one of my heroes. That's why he's up there. But their style of medicine was so different than it is now. It's just, you know, I could talk about 2 hours on this. But he set up the whole system of interns, residents, basically the pyramid system of teaching. So he was an impressive guy. But he's the one who said, and this is why I bring him up, he said, talk to your patient. If you talk to your patient long enough, he's going to tell you the diagnosis. And it's true. If you ask enough questions, you're going to get the diagnosis. You won't need to go through a bunch of tests. So the idea is that the old style of approaching it, and I actually am in that category of that training method, and that is 90% of your ability to come up with the real answer is actually through the history. It's not through fancy tests. So here we go into the storybook issue. And these are the types of things that you could ask friends or parents that might be having problems. What's the duration? Did the patient have a period where they actually got better and then they got worse again? Impact of physical or mental activity. In other words, did physical activity make things a little bit better or mental activity? And here's a level of activity and presence of weakness. So that's important too, because that puts you down a different corridor when you have the presence of weakness. Seasonality. Does anybody know like how seasonality would affect us? Sunshine and also lack of, right? SAD syndrome, seasonal affective disorder. So half the population of Altoona by the end of January is depressed. Now, they're not morosely depressed, they're not catatonic, but they are clearly blue, they're down. Why? Because they haven't seen the sun. And the sun does get us going, there's no question about it. Modifying factors, well, those are things that has to do with how we can modify or help them modify their illness. And sentinel symptoms, this is pretty interesting. I think it is worth looking at. So first off, first listed is travel and infections and vector exposures. So that means, have you been out of the country? Have you been in another area where perhaps they have well water? Of course, we never have well water in this area, do we? No? A lot of people have well water. It's a very, very big thing. We have, in the summertime, in this area, there's Giardia and a bunch of other parasites. Not to see if I want to talk parasites. But these are things that are very common. They're not paid attention to by many people. Immunosuppression, CMV, cytomegalovirus is very common. For us, it doesn't hurt us, but if you're depressed, it does. Immunodepressed, that means you can't fight it. Tick exposure. So we all know that Lyme's disease is around here. How many people knew that, I'd say one of every 2 tick bites is actually infected? In other words, the patient gets infected with Lyme's. That's what it is now. And it turns out that a vast number of those infections are two different bugs at the same time. So and that's why they're having problems solving the problem with Lyme's, because it's more than Lyme's. Does anybody know what the center, where the epicenter of Lyme's is, as far as where is it the highest level and all that? Anybody? Yeah. Where? Huntington. Huntington is the epicenter, highest degree of positive findings in the country. Huntington. So we have it bad here. We have it bad here. And also our studies, our evaluations for Lyme's is second rate, okay? We end up, they'll do a Lyme screen, which 90% of the time is negative. So just for your own sake, you're not going to be talking about Lyme's, right? I didn't think so. So for Lyme's, it would basically, you would get a Western blot. That's the test to get. And if you don't get a Western blot, then you really haven't been evaluated correctly. Now you've got some other things here. Sleep deprivation, a big, big issue. So here's a situation where a person has sleep deprived. Why? They're working hard. They're working hard. They're not really having the time to sleep well. And then the next step because of that is and it doesn't matter if it's male or female, they will take stimulants to keep themselves going. Why? Because they have to. So they'll be drinking coffee. Caffeine is number one. So, boomers will drink coffee. The younger people would drink a Mountain Dew or something like that. All right? So very common. Other stimulants, yes, but not as much. Caffeine is by far the biggest stimulant involved. And caffeine, a small amount of caffeine is fine. If you have a large amount of caffeine, it is dangerous. I'll give you a little story. 2004, 2005, we had 5 young ladies. 3 of them were girls, 18, 19, 21. The oldest was 27, so 5 girls who they all came in at different times through that period with massive heart attacks. We're talking like an 18-year-old girl with a massive heart attack as if they were an old man. Tombstone elevations. When you see this, it's scary as whatever, okay? And so how do you deal with that? Well, the first thing, you're trying to stabilize the patient, but the second aspect is, well, what's going on? So after the patient stabilized, we would do a heart cath and figure out, interestingly, remember the cath is about 5 hours after the initial onset. So by doing the cath, we shoot the arteries, and it turns out they're totally normal. I mean, pristine, beautiful arteries, no plaque, nothing, okay? So after that, we say, well, this is spasm. It's coronary spasm. The question is why? One of the girls did have a use of cocaine in the past, but nothing recent. So we're trying to do more detective work to find out what really was. And here's what it was. All 5 girls drank a 2-liter bottle of Diet Pepsi every day because they were trying to lose weight. And that's 64 ounces of a caffeine-containing cola, and that was enough to cause the spasm of the coronary artery. And it would go into spasm, for 20 minutes to 40 minutes, whatever, and that's enough to cause a heart attack. So by the time we actually had done the heart cath, the artery had opened up, the spasm was released, but the child or the young lady is still having a heart attack. I mean, the person did suffer heart damage. It wasn't a mirage, it was real. So they all have, real issues as far as their hearts not being the same as they were. And that was all because of drinking that much caffeine. Now, it doesn't matter what the product is. It could be Mountain Dew, Coke, it doesn't matter. It's the concept of that much caffeine is enough to cause the spasm. So, going through the other ones here, we have polyuria, visual defects, and then here's cold and heat intolerance. All these things are symptoms that point us in different directions. Look at the last one I think is relevant, and that is paresthesias, blurred vision, psychiatric changes, like the person's acting maybe a little delusional or something along those lines. Or they could have, in the bottom you can see cognitive decline, ataxia, and heavy metal toxicity. we had a case where a guy was acting this way. He had paresthesias. He was acting kind of strange, but the big thing was he was acting as if he had dementia. And we couldn't figure out what was going on. Then we did some studies, and it did show that he had lead poisoning. So we figured, well, that's good. We'll give him some type of chelation therapy and hopefully get rid of that. So we do the chelation, his numbers get better, and then 6 months later, he comes back with the same thing. And we're saying, what in the world is going on? And so he was somehow getting further lead toxicity. It turns out, after asking some questions, like, like simple things like, hey, what do you do, and this and that, and he goes, so he fishes, okay? So he was a fisherman, not a big boat, but like just regular type of fishing. And he had I said, did you use lead weights or anything like that? And because I remember when I was a kid, my father, he would take the lead, and these little weights would have a little space, and you could crunch it down on the line, and sure enough, that's what he did. He did the same thing I did when I was a kid. You took it and you like that with your mouth or your teeth, and next thing you know, the lead weight's on there, but the lead's going into his system. And that plays a lot of problems with the lead is a big deal. It affects the brain, affects the blood system and all that. So, psychiatric screening. Well, this is important to know also, but I'll just read it out for the sake of being complete here. So it says 25 to 33%. So let's say 1/3 of primary care fatigue patients are depressed. Does that really surprise you? Maybe the percent, 33% or 1/3, but let's face it, people who are depressed are commonly fatigued. They typically will sleep longer. They'll just be moving slower. Now, this PHQ screening tool is really good. Was that included in our paperwork? I don't know if no. That's it right there. Okay. So let's show that up here, and I'll show you why I'm presenting this here. That's it right there. Okay. This is a standardized 2-question, simple how to evaluate the patient's psychiatric status. I'll read this out. And like, for example, they'll give this to kids in college. Let's say, someone's having problems and they go to their college clinic or something like that. And also this is the type of questions that the family doctor would ask as well. So at the very top, you say, over the past 2 weeks, how often have you been bothered by any of the following problems? And they would list here little interest or pleasure in doing things. That's a pretty good thing to ask, because when you're depressed, you're not really interested in anything. And as your progression gets worse, it gets closer to 0. Now here, the next question is, this would apply to over the last few weeks, feeling down, depressed, or hopeless. So naturally worse would be on number 3, nearly every day. So when using those 2 questions only, you add the score up, and then this at the bottom, it says probability of a major depressive disorder is according to those numbers there. So this is actually quite easy and also important, because we have so much of our mental health system has a long way to go. It's really insufficient, and it's unfortunate, but it's true. And so having something like this like a family doctor could ask every patient the same questions, and they would fill it out, and that would give him a better insight on things, or her. I think this is almost to the end here. So last thing here, this has to do with sleep. Sleep is what? It's the ultimate vitamin. Now, there's a reason. Our bodies are made to have sleep, and without sleep, we cannot recover. We cannot repair. You could spend $200 a month on vitamins, I don't care what they are, and it's not going to work. It just won't work, because you have to have repair performed first before any of these vitamins can add to it. And there's one exception, and that is in Australia, there's a guy who put together a a system of vitamins, and he starts the patients off with just a very small amount of every vitamin. And they take like 20 capsules a day, but what they're doing is he's ensuring that every vitamin and mineral, they're all in one, one product, and after a period of 6 months, they basically have gotten equilibration of all their minerals and vitamins. And it turns out, using that particular product, a lot of patients who were depressed are no longer depressed. And also their psychiatric issues and even some autistic issues have been helped. So it's amazing how important it is. But despite that, they all had to have sleep ahead of time. And sleep is a big issue because most Americans aren't getting enough sleep. And starting from the 70s, when women started going into the workforce, they start having sleep depression or sleep deprivation, I mean. And for that reason, it's affected the family as well as the patient. Sleep apnea is the other aspect to lack of sleep, and sleep apnea is extremely important. Essentially, more than half of all the men over 50 who are not skinny or carrying some weight have sleep apnea. And why is it important? Because sleep apnea typically is something that gets worse slowly. And what it does, in the final take-home point with the sleep apnea is it will cut 10 years off your life, and the last 10 years of your life are not as good as they could have been. And most people are looked upon as if they're having early dementia, but they're not. They're not. And so what happens is, if they're caught early, they use the CPAP typically. They could lose weight, but most people can't lose quickly. So CPAP is something that does work. And so for those patients, they have a remarkable improvement. I mean, it's remarkable. Basically, after maybe a year or so, their brains are back to what it was maybe 10 years before. Because the reason is because with sleep apnea, when they're having those spells where they're not really having proper breathing, they are also having a deficiency of oxygen, and long-term oxygen deprivation in the brain is not good. So, and we'll do physical examination some other time. Let me finish here. Okay.
So you're coming back in January then?
I don't think so, but it might be February.
Oh, wow.
Whatever. So, yeah, the idea is, so today's discussion was to show the breadth of this whole issue of tiredness and fatigability, and it really involves not just simply the fact that, I can't run the 100-yard dash anymore. It has to do with our emotions, our lack of sleep, lack of proper nutrition, all these different things. It's not a simple thing that, we simply have a lack of ATP and et cetera. It's more than that, okay? So the most important take-home point is in fact, you can look at what I've written down here. One of the key issues is that if you have fatigue or you have loved ones who have fatigue, talk to them and try to sort out what it's all about, all right? So from there, you can, help guide them to be seen by somebody. That's one. Number two is, if it's yourself, here's the hard part. It's very hard to be honest with yourself because you figured you could just simply gut it through and just keep doing it. But in the end, you need to really improve because it affects the quality of life. Sleep apnea, 43% of, half of all the patients who were killed in head-on collisions are sleep apnea. 43% of everyone who dies in bed asleep is sleep apnea. Okay, so those are big numbers. 43%. That's nothing to take light of. So this is just the beginning of our discussions on this. The next, or part two, is going to be involved with pretty much explaining how this all happens. Okay, so thank you for listening to me, and if you have questions, we can talk about that afterwards.
Thank you.
All right, thank you.